Good afternoon from Miami Beach. This is Dr. John Bennett, inviting you to another episode of the Association of Future African Neurosurgeons. Djiofack is going to give this presentation. We're having a few technical issues, but we're going to try to work through this. I'll be sharing the PowerPoint. We are joined by a couple of guests. Let's introduce them first. Good day, Dr. Kabulo.
Thank you, Dr. Bennett. My name is Kabulo. I'm final year neurosurgeon resident at the University of Zimbabwe. I'm originally from Democratic Republic of Congo.
You're welcome, Dr. Kabulo, and thank you for being persistent and staying with us. We'll try to get through this. Okay, Dylan, you just let me know when you need to change the slides. I'm going to put it up right now, okay? And
okay,
please introduce yourself first, Dylan.
Hello, everyone. I'm Dylan Djiofack, recently medical doctor from Cameroon. Nice to meet you all. I'm a member of the Association of Future African Neurosurgeons. So, hello, everyone, once more. Today, we'll be talking about the pituitary gland. So, what's generally known as the master gland. Next, John. And in order to reach our goals, in order to reach our goals of the day, we are going to follow a plan that includes a brief introduction, a walk through the embryology of the pituitary gland, surgical anatomy with focus on some relevant structures as to what surgical operations on the pituitary glands is concerned. We are going to talk about the functions of the pituitary gland briefly, the clinical relevance of this surgical anatomy, and then we'll discuss precisely the most used surgical approach in the surgeries for pituitary tumors specifically. Next slide, John. So as an introduction, the pituitary gland is also known as the master gland. It is a major organ in the endocrine system, because the term the master gland, because it controls the endocrine activity of many other glands of the body. So the name pituitary gland has as main justification only a historical evolution, because before the 17th century, Galen described the pituitary gland. At that time, it didn't carry this name yet, but it described the pituitary gland as one of those glands involved in the production of nasal mucus. So Andreas Vesalius termed this pituitary gland glands in quam pituita destillat, which means the gland from which mucus drips. So the pituitary gland initially was considered as one of those glands responsible for the production of nasal mucus. It's only after the 17th century, when this theory was debunked, that the name glandula pituitaria, which was also introduced by Andreas Vesalius, glandula pituitaria, which has as British meaning pituitary gland, remained, and later on hypophysis too was introduced. So these two terms remained. Next slide, John. So as we can say that the pituitary gland is this small gland that is located inside a part of the sphenoid bone, which has the shape of a Turkish saddle called the sella turcica. So next slide, John. Embryology, it has two main parts. Sorry, it has an anterior part, which is termed the antehypophysis, which comports the pars tuberalis, the fibrous trabecula, the pars intermedia, and the pars distalis, which all originate from the Rathke's pouch. And then it has a second part, the post-hypophysis or the neurohypophysis, which contains fibers extending from hypothalamic nuclei from above. Next slide, John. So as we were saying, embryologically, the hypophysis of the gland has a double origin. The anterior part of the pituitary gland originates from Rathke's pouch, which is an ectodermal extension of the embryonic stomodeum. The stomodeum is the epithelium of the buccal cavity. So from this stomodeum, there is this ectoderma extension that is going to meet posteriorly the extension from the neural ectoderma, which represents the infundibular origin of the hypophysis, which on the other hand is going to give the neural hypophysis. So anterior hypophysis originates from Rathke's pouch, which gives the pars distalis, the pars intermedia, and the pars tuberalis. Rathke's pouch, we can see it in red here. You can see it in red. It will be responsible for formation of the anterior hypophysis, and then the infundibular origin, or which will form the neural hypophysis posteriorly, which is an extension of the hypothalamus, extension of the neural fibers from the hypothalamus, will form the post hypophysis. Next slide, John. So here again, we see, as we said, the extension. We have the infundibular origin, which will later on merge with the posterior part of the anti-hypophysis, and in itself would form the post-hypophysis or the neurohypophysis. Meanwhile, Rathke's pouch, originating from the stomodeum, will merge anteriorly with the post-hypophysis to form the anti-hypophysis. Next slide, John. So, as we said, the adult pituitary gland has two main parts: an anterior part, which is the main glandular part of the pituitary gland. It is that part that's capable of synthesizing the hormones which are responsible for the control of the activity of other endocrine glands. And the neurohypophysis, on the other hand, has fibers extending from the hypothalamus, precisely the paraventricular and the supraoptic nuclei of the hypothalamus, which give fibers, which extend into the neurohypophysis and store the hormones produced from the hypothalamic structures, precisely oxytocin and antidiuretic hormone. Next slide. So anatomically, as we said, the pituitary gland is this pea-sized ovoid-shaped structure residing in the sella tussica, which looks like a Turkish saddle, weighing 0.5 grams and suspended to the inferior surface of the cerebrum by a stalk, pituitary stalk, also known as the infundibulum of the pituitary gland. And superiorly, it is covered by a diaphragm cella, which is a fold of the dura mater, which covers the superior part of the pituitary gland and allows passage for the pituitary stalk through a hole through the diaphragma cella. Next slide. So the pituitary gland has relationships with surrounding structures, because being mainly an endocrine organ, what it's most interesting in this surgical procedures is to know the surrounding structures, which will be interesting when taking on surgical procedures, which pathway to take, which organs are going to be encountered. So it has relationships anteriorly with the sphenoid sinus, both anteriorly and inferiorly. We can see the sphenoid sinus just anterior-inferiorly to the pituitary gland here, that gray space anterior-inferiorly to the right. Posteriorly, it has relations with the posterior intercavernous sinus, better seen in another slide. The dorsum sale, which is the posterior part, just behind the sella tussica, the part that slants towards the clivus. And then the basilar artery and the pons, as we see, just posterior to the pituitary gland. In red, we have the basilar artery, and just behind the basilar artery, we have the pons. Superiorly, as we said, it is covered by the diaphragm cella and then the optic chiasma, which can be seen in this diagram. And then inferiorly, still with the sphenoid sinus, which is a very relevant structure during surgical approaches to pituitary lesions, precisely pituitary tumors. And then laterally, it is in close relationship with the cavernous sinus. Next slide, John. So talking about the sphenoid sinus, as we know, it is that cavity found inside the center of the sphenoid bone, and it is located just anterior inferiorly to the sella tussica, where the hypophysis or pituitary gland lies. Next slide. Then we have, we can see just surrounding the area of the pituitary stalk and the pituitary gland, we see posteriorly, we have the intercavernous sinus, the posterior intercavernous sinus, which is in close relationship, as we said, with the pituitary gland. Next slide. Also, the pituitary gland, oh, I can't see the slides anymore, John. Maybe. Can you hear me, John? I can't see the slides anymore. Okay.
Dr. John, go now on your left corner, inferior, yes. You use those arrows to go to the next slide, yes.
Next, it's not yet there, John, not yet. Not yet, not still. Next. Next slide. Next one again, and then the following slide. The next slide. Okay, so it has the pituitary gland too has relationships with cisterns, those subarachnoid spaces filled with cerebrospinal fluid, and precisely the suprasellar cistern, as is seen just above the area of the pituitary gland where it is written P in green color. Just above, we have the suprasellar cistern. Next, John. So, as we said, posteriorly now to the pituitary gland, we can see better the relationship of the pons, as it is located posteriorly, and just between the pons and the area of the dorsum sale, which is just posterior to the sella tussica, we have no, not yet.
I'm sorry. I think I'm going to be fired from this job.
No, it's.
I'm sorry.
Really,
next slide.
No, just go back. I was still. No, backward. Backwards.
Okay, I'm sorry. I got the wrong.
No, you are still going forwards, John. Go backwards.
Okay, I'm trying to go backwards. Is that backwards? Is that okay?
Yes, it's okay. So backward again. Again. It's okay. It's okay. Thanks, John. Okay. So the pons located posteriorly to the pituitary gland, and between the pons and the area of the dorsum sale, you have the basilar artery that passes there. Next slide, John. Superiorly to the hypophysis, we have a better representation, but precisely this better representation is for the optic chiasma, which you can see here, which has an X shape. It looks a little bit like an X, which is the crossing of the two optic pathways, just above the pituitary gland, which we see inferiorly to the left here. And then to the right, we see still the optic chiasma, just located just above the pituitary gland. Next slide, John. Laterally, as we said, the pituitary gland is in close relation with the cavernous sinus, in which we find vascular structures, the branches of the internal carotid artery, and then nervous structures, precisely branches of cranial nerves, 3, 4, 5 sub-branches, number 1, and then number 2, and then the abducens or 6th pair of cranial nerve. And all of that located laterally, and below we have the sphenoid sinus. So during surgical procedures, especially when we have the transsphenoidal, the endonasal transsphenoidal approach, we come into real close relationship with these surrounding structures, and precisely we have the prominences of the internal carotid artery. So during incision, in order to access the pituitary gland behind the sphenoidal sinus, has to be taken to circumscribe the incision in order to not to get in touch with the carotid arteries prominences. Next slide, John. So as we said, in this the surgical procedures for the pituitary gland, the most used surgical procedures, especially for pituitary tumors, the transsphenoidal approach. So looking into more details concerning the transsphenoidal approach and the relationships during this approach. Next slide, John. We have here an image of what the posterior part of the sphenoidal sinus looks like once it is accessed by the neurosurgeon through an endoscopic approach, most often the endonasal endoscopic approach. So here we'll see the planum sellae, we'll see the inferior portion of the sella tussica. So we know that just behind this portion, we have directly access to the pituitary gland. And laterally, we see the prominences of the internal carotid arteries. Inferiorly, we see the clivus, that posterior part, the posterior slanting part of the sphenoid bone. Next slide. So during this surgical procedure, this is an image to describe a little bit what is located behind the posterior wall of the sphenoidal sinus. So we see the pituitary gland at the center, the circular structure, and laterally we have the internal carotid arteries, as was demonstrated previously with the prominences of these internal carotid arteries. The essence of this approach is that once we are going through endoscopically during an approach to the pituitary gland, this is approximately the way the posterior wall of the sphenoid sinus presents itself. So represent or seeing these structures beforehand helps locate the extent to which the surgical incision is performed in order to access only the pituitary gland without any injury to the closely located internal carotid arteries. Next slide, John. Here again, we see another representation of the relationships around the pituitary gland. So in the top left image, we see we are looking at the sphenoidal cavity anteriorly and anterosuperiorly a little bit, and then we see the optic chiasma just above the pituitary gland, which is located behind the posterior wall of this sphenoidal cavity in which we are. So we see the optic chiasma above. We see the carotid artery prominences, and then just lateral to these prominences with the carotid arteries, we see the branches of the cranial nerves present in the cavernous sinuses, as we said, laterally to the pituitary gland. On the top right image, we have a lateral view of the sphenoidal sinus, the view which we have generally when we perform a sagittal cut of the bony skull. And here we can see the sagittal sinus, we can see the pituitary gland in the sella tussica just above. And then we remark the close relationship of the internal carotid arteries, which are really very important structures during these surgical approaches. Here we have, at the bottom left image, we have a superior view of the sella tussica. We see the diaphragma sellae. Above diaphragma sellae, we have the optic chiasma. we have the branches of the internal carotid arteries as they start lateralizing. And then we have inside the sella tussica, we can see the pituitary gland in a little brownish structure. And then anteriorly, we have the surrounding structures. And then again, the cranial nerves that are present in the cavernous sinus laterally to the pituitary gland. Next slide, John. Here again, still an image to better represent the pathways and the relationships between the pituitary gland and the carotid arteries and the branches of the cranial nerves and the optic chiasma. And this is still a look into the sphenoid sinus anteriorly from an anterior view, just as the surgeon, as a neurosurgeon views the sphenoidal cavity when he's performing an endonasal, an endoscopic endonasal transsphenoidal approach. Next slide, John. So here again, we still have our diagram with the floor of the sella tussica with the planum sali with the internal carotid arteries, the clivus. Next slide. And here we took a real life image. So having those landmarks, we can see still here we have the sella. We can see laterally the prominences of the carotid arteries. We can see the planum sali just above, and then we see the clival recess just below. So just in the way we see it during the surgical procedure. Next slide. Next slide, John. Here we see the sella to still the posterior wall of the sphenoidal cavity. Once a part of the posterior wall has been removed, layer by layer, we see the meningeal layer, we see the periosteal layer, we see the intercavernous sinus, the anterior part of the intercavernous sinus, and then just posterior to this, we have directly access to the pituitary gland, as you can see on the right. Once the thin layer of bony structure of the posterior wall of the sphenoidal sinus has been removed, we have directly access to the pituitary gland, an enlarged pituitary gland. In case of tumors, then the pituitary gland will be, the tumors can be removed from the pituitary gland, and then the surgical procedure will progress. Next slide, John. So talking about the blood supply of the pituitary gland, and the anti-hypophysis and the post-hypophysis have a certain correlations as far as the blood supply is concerned, but there are differences. The anti-hypophysis obtains its blood mainly from the superior hypophyseal artery, which is a branch of the internal carotid artery. These superior hypophyseal arteries form two capillary networks, one at the level of the hypothalamic region and the other at the level of the anterior pituitary region. So the essence of this relation with the superior, between the capillary networks of the hypothalamus and the pituitary gland, is that it permits the hypothalamus to secrete the releasing hormones that will control the activity of the anti-hypophysis. As far as the post-hypophysis and the infundibulum are concerned, they obtain vascularization from a whole lot of arterial branches, but the main arterial branches are the superior and inferior hypophyseal arteries and the infundibular artery, mainly for the infundibulum. Next slide, John. So talking about the functions of the pituitary gland, it is a really delicate organ once it is concerned by a lesion during surgical procedures, because as we can see in literature, it is the organ that controls many of the basic functions as far as the endocrine system is concerned. And we know the close relationship between the nervous and the endocrine system as far as controlling the day-to-day activities of the human being and easing a certain number of functions is concerned. So the anti-hypophysis produces hormones controlling the thyroid gland, the adrenal cortex, the ovaries for the menstrual cycle in women, the testes in men for reproduction, and then normal growth and production of or lactation, galactogenesis in women. As far as the post-hypophysis is concerned, it does not produce the hormones as the anti-hypophysis does, because it lacks those glandular structures, but rather it stores the hormones produced by the hypothalamus and sent through the neural fibers, which you can see go through the infundibulum to reach the post-hypophysis. So the substances produced or secreted by this post-hypophysis include oxytocin, which acts at the level of the mammary glands during lactation, and on the uterus during uterine involution after a pregnancy or even in uterine contractions. And these hormones originate respectively from the suprachiasmatic nucleus for antidiuretic hormone and the paraventricular nuclei for oxytocin. So with all functions, each time the pituitary gland is concerned with a pituitary tumor, which by the way is the fourth most frequent tumor of the central, most frequent intracranial tumor. So each time this pituitary organ is concerned with these tumors, one question that comes into play is what next? After the surgical procedure, what becomes of the hormonal functioning of these patients? So all of that has to be managed generally in association with an endocrinologist, as it is an organ that's a little bit shared between the neurosurgeon and then the endocrinologist. Next slide, John. So clinically, when in case there is a pituitary lesion, and in our case, we're talking mainly about the pituitary tumors, that is most frequently, that's the main indication of concern for the pituitary gland as far as neurosurgery will be concerned. So when there's these tumoral lesions at the level of the pituitary gland, the signs and symptoms are linked to, on the one hand, the increase in intracranial pressure, because the tumors, especially when it's a macro lesion at the level of the pituitary gland, there is an increase in intracranial pressure that is responsible for headache, as we can see in this woman, for headache, for vomiting in some cases, though it's not really that much frequent with the pituitary tumors. And on the other hand, the signs and symptoms will be linked to the mass effect on the surrounding structures of the pituitary gland. So as we know, surrounding structures, mainly the most sensitive structures, are the structures that are present either superior to the pituitary gland, we are talking about the optic chiasma, or laterally to the pituitary gland, we're talking about the structures present in the cavernous sinuses. So in which case, in patients who sustain macroadenoma of the pituitary gland, they have visual field defects, and most typically they have a bitemporal anopia, bitemporal hemianopia. So they have these lesions with which concern the lateral parts of the visual fields on each eye, which are due to the compression of the optic chiasma when there's a pituitary lesion, as we can see here, especially when it's a macroadenoma. On another hand, the symptoms present due to the type of tumor, whether it's a hormone secreting tumor or it is a non-functional tumor. Next slide, John. In which case, when we have a hormone secreting tumor, depending on the type of hormone, if it's a growth hormone in an adult, we have acromegaly with facial changes, airway obstruction, laryngeal narrowing, barrel chest, and chronic renal volume increase. And on the other hand, if it is, for example, a cortisol secreting or adrenocorticotrophic hormone secreting tumor, would have Cushing's syndrome due to hyperstimulation of the adrenal gland. As we can see on the lower left image, we see that there's headache and visual field defect, and then we have the mass effect on the surrounding structures of the pituitary gland. Next slide. So here we can visualize still our pituitary tumor. Here we have a macroadenoma, which literally invades the surrounding structures, compressing the optic chiasma above, as we can see, and then the carotid arteries below, which can be associated with cerebral ischemia, compression of the carotid arteries, or even compression of the cranial nerve branches just laterally. Next slide, John. So talking about the surgical approaches, next slide. Generally in sphenoidal, pituitary tumors, the most used surgical approach is a transsphenoidal, precisely the endoscopic, endonasal, transsphenoidal approach. Initially, it was a microscopic approach used, but with modern neurosurgery, it is an endoscopic, nearly completely endoscopic approach that is used. Then, besides that, we have transcranial approaches, which are used in really rare cases of true invasion of the surrounding structures in relation to the pituitary gland. In case we have a really invading structures, that a really invading tumor that cannot be removed simply with the endoscopic approach. If not, the main and most adequate approach is the endoscopic and mainly endonasal transsphenoidal approach. Next slide, John. So this approach has many advantages. So it avoids the need for the oral and the rhinoseptal submucosal nasal route, as those were some other routes used in order to access the sphenoidal region. The spatial features of the telescope used during this approach permit better exposure of the operating field with the surrounding organs. As we know, many vital organs surround this pituitary organ, so it is really very important to be able to visualize the structures, separate them clearly in order to access only the pituitary gland, avoiding injury to the carotid arteries, which can cause real stress during the surgical procedure or can even lead to the death of the patient. The high resolution and close-up view due to the endoscopic device used, it has an improved post-operative course with the patient, which increases the comfort of the patient. It avoids the need for post-operative nasal packing, as most often was the case, and thus minimizes breathing difficulties and discomfort for the patient. Next slide, John. So we're going to go a little bit through this endoscopic endonasal approach, an endoscopic exploration as to how the neurosurgeon generally approaches this sphenoidal cavity and how the surgery proceeds. So there are three main stages in this approach. We have the nasal stage, the sphenoidal stage, and then the sellar endoscopic opening. So at the nasal stage, first of all, as we can see on this image, when the endoscope is placed, noting that in this surgical procedure, the endoscope is mainly used for visual purposes. So when the endoscope is placed parallel to the floor of the nasal cavity, what we visualize on the left image, we can visualize the inferior turbines. You can visualize the inferior turbines, and laterally we have the nasal septum. So next slide, John. As we proceed a little bit further anterior-posteriorly, still parallel to the floor of the nasal cavity, as the image shows on the right with the blue arrow, we can visualize just beside and above the inferior turbinate, the medial turbinate, and deeper we can visualize the choanal regions. Medially, we have the nasal septum. Next slide, John. So the target is going from that level. We go superiorly 30 degrees to the nasal floor, and we visualize the medial turbinate. We visualize the choanal region, and laterally we visualize the sphenoethmoid recess, as you can see laterally to the right. So this recess is if I can say, the pathway or the landmark that permits going superiorly access to the sphenoidal ostium, as we'll see on the next slide. Next slide, John. So we have the sphenoethmoid recess, which is lateral medial to the middle turbinate with the nasal septum medially. Next slide, John. Going a little bit upward, following this sphenoethmoid recess, we reach the sphenoid ostium, which is just ahead of the opening of the sphenoid sinus. Next slide, John. So here we visualize the sphenoid ostium, and from this sphenoid ostium, we can visualize directly the internal part. As the arrow shows to the right, we are visualizing the internal part of the sphenoid sinus, and already we can depict the cellar floor. As we said, we can depict the clivus below, and we can see the prominences in pink, the prominences of the carotid arteries and the planum sella just above. Next slide, John. Still here we have a better representation of this view through the sphenoidal ostium with the planum sella above, the cellar floor below, knowing that the cellar floor is just that the inferior part of the cellar tussica, which is a thin bone region that separates the sphenoid sinus, in which we are visualizing during the surgical procedure, from the pituitary gland just posterior to this cellar floor, and laterally we have the carotid prominences, which have to be taken care of in order to avoid any injury during the surgical procedure. Next slide, John. Here again, we can see at this level, we are already at the sphenoidal stage. That's we are visualizing we are already with the endoscope into the sphenoidal sinus. So we can see once more at the level of the left image, the cellar floor. We have the clivus below. We have the prominences of the carotid artery and the planum sella just above. And then knowing that from our initial image, just posterior to the cellar floor, we have the pituitary gland. Next slide, John. Here again, images just to remind us of the relationships of the organs located behind the posterior wall of this sphenoid cavity in which we are looking. We see the pituitary gland just behind the posterior wall, as we said at the top left image. We see the carotid arteries and the optic chiasma just above. Next slide. So at the next stage is the endoscopic cellar opening. So after the removal of the little bony structure of the posterior wall of the sphenoidal sinus, in which we are already observing, as we can see, we go further directly to the pituitary gland, and the dotted marks which are present at the level of the left image, the dotted marks represent the area to which the incision or the removal of the bony structure has to be circumscribed, because as we realize, directly beyond these bony marks, we have the prominences of the carotid arteries. So beyond these marks, surgical procedures will lead directly to the injury of the internal carotid arteries, which will cause massive bleeding during the surgical procedure and risk of death of the patient. So after the removal of this posterior wall of the sphenoidal sinus, we have the pituitary gland, and then which can be the tumor present at the level of this pituitary gland can be directly removed. And then after, we have a cellar repair in order to prevent CSF fluid leakage. Next slide, John. So in conclusion, the pituitary gland is a major gland in the endocrine system. It is one of those structures in very close relationships with the vascular and the nervous structures of the central nervous system. So each time it is concerned, what next concerning the endocrine?
Excuse me, Dylan, turn off your video picture, please. That might help the bandwidth.
It's turned off.
Oh, okay. Okay. Go ahead.
Okay.
Go ahead.
So I was talking about the conclusion. So as I was saying, the pituitary gland is a major endocrine structure, very important both by the important vascular and neurological relationships around this pituitary gland and its important endocrine function for the normal functioning of the human being. So each time it is concerned, especially with pituitary tumors, which are the fourth most frequent intracranial tumors, according to the American Association of Neurosurgical Societies. Each time it is concerned with these tumors, there is one concern on the one hand, we have what next concerning the endocrine functions of this patient, because these tumors, as we remove the lesions, especially when it's a macroadenoma, because microadenoma, not necessarily surgical procedures is concerned, but what next concerning the endocrine function of this patient. And then during the surgical procedure, is true, the most used is transsphenoidal, but the important relationships present around the pituitary gland make this organ a really sensitive organ during neurosurgical approaches. Next slide, John. Thank you for your kind attention.
Okay, Dylan, we made it through.
Yeah,
we
finally.
had some. Yeah, that's very good,
Yeah.
very good. Like I say, when you're a neurosurgeon, sometimes the equipment doesn't work the way you want it to.
Exactly, John.
And it doesn't help to start yelling at people and throwing instruments around, and it just doesn't help. And there you go. You got through the entire presentation. We just cobbled our way through. Let's start first with the neurosurgeons if they have any comments. Dr. Cabullo, do you have any comments or questions for Dylan? Are you there, Dr. Cabullo? Or Dr. Naru, whichever. We just joined late.
Hi, John. Hi, everybody.
Hey, Naru, welcome, welcome. We don't see a picture there. Is your video camera working?
Yes.
There you go. There you go.
Yeah. Thank you, Zolo, for your brilliant presentation about anatomy of hypophyseal region. Very nice, very clear. And I love when you done good correlation with a clinical topic with anatomy with this region and the correlation with surgical procedure and but I don't know if you talk about vascularization because maybe I missed this part, but I don't know if you talk about the port system hypophyseal because in hypophyseal region the vascularization is very typical. I don't know if you talk about that. But of course, I enjoy your presentation and thank you so much, Zolo.
Okay, very good. Dr. Cabullo, are you there?
Yes, I'm there.
Okay, do you have any comments or questions for Dylan?
Yes, thank you. Thank you so much, Dr. Dylan. It was great. What I wanted just to, my comment, I have few comments. He mentioned almost everything because talking about pituitary, it's a broad, huge topic. You know, these days people are just writing a book on pituitary, So talking about pituitary, it's not easy. Thank you for this wonderful presentation. What I wanted, just my comment was on embryology. I don't know if he mentioned it or maybe I missed it. The development usually it's okay between the 3rd and the 15th week of gestation. And also, I don't know if he mentioned about the size of the pituitary gland.
Thanks, Dr. Cabullo. I didn't mention it about the size.
You did mention okay.
No, I talked about the weight.
You talk about the weight. Yes, I saw the weight. Yes, and
not the size.
Yes, about the weight. Usually during pregnancy, the weight increases. It can go up to 1 gram.
Yeah.
And yes, the size usually in transverse, it's 18 millimeters, and the AP diameter is like 9 millimeters, and the height 6 millimeters. That's the average for pituitary gland.
Okay, thanks.
Then,
Dr. Cabullo.
Yes. Then also the anterior lobe. The anterior lobe is the one which occupies 80% of the gland, and the posterior lobe just occupies 20% of it. So I enjoyed the way you divided the gland into two, and also the microscopic division. You talk about anterior lobe with 3 divisions, the pars distalis, the pars intermedia, and pars tuberalis. Here I wanted just to mention, to emphasize that the pars distalis, it's the largest, and it's the hormone producing cells. The hormone producing cells are more on that pars distalis. And if you check histologically, you see that it's the largest comparing to the other 2, because the pars intermedia, it's poorly defined in the human. So, and the pars tuberalis is just up there, and a small portion. And in the posterior lobe, you get now the pars nervosa. And according to like what I was saying, pars distalis, usually inside there, since it's the part, the largest part, and the cells which are producing hormones are in that area. That way you get your pink acidophils, the dark purple basophils, and remember the acidophil cells, they are secreting the growth hormone and prolactin, and the basophils, they secrete the rest of the hormones like ACTH, TSH, FSH, LH, and so on. So I think my other comment, like Nuru was saying, you should also mention, I don't know if you mentioned about the vascular supply, the arteries which are going to the pituitary. Maybe I missed that one.
Yeah, thanks, Dr. Kabulo. We talked about the vascular supply, though not very much in detail, but to mention the superior hypophyseal artery, inferior hypophyseal artery, the infundibular artery, and then the network at the level of the hypothalamus and the hypophysis.
Yeah, it's okay. Thank you so much. Okay. So those were my comments. Then about the approaches and the tumors which can, okay, the clinical correlation, it was okay. It was shallow because the topic is huge, like I was saying. But usually, my question I wanted to ask you, how is the vision when you get a pituitary tumor compressing the optic chiasma? How do patients present in terms of vision?
Oh, okay, thanks, Dr. Kabulo. The patients present with, okay, I know it mostly in French, is hemianopsie bitemporale. That it it's bitemporal hemianopia.
Yes, good. How does it start?
How does it start? Okay, I don't really master.
Usually it starts with the upper quadrant going to the lower quadrant. They say it's like curtain going down, from up going down. You get it?
Okay, like thanks.
The curtain from up going down. So it will start with the upper quadrant, then going down, involving now the lower quadrant. Then you get bitemporal hemianopia. That's a sign which can tell you that there's something which is going on the
pituitary.
Yes. Okay. So I think it was okay. You went through the surgical approach. The transsphenoidal approach is, of course, now these days people are using that one. It has also some limitations, especially when the tumor is big, extending laterally. You can't access it from below. So you have to go, you do a transcranial approach. Though these days people are now doing the extended transsphenoidal approach, but if the tumor is going into the third ventricle, extending laterally, usually you won't reach it from below. You have to go transcranially. And sometimes you can do both the transcranial and endoscopic. You combine both approaches to remove the tumor. Otherwise, it was perfect. Thank you so much for that great presentation.
Okay, thanks, Dr. Kabulo. Your remarks were great. I've really taken note. Thanks.
Thank you, Dr. Kabulo. Thank you. I'm sorry I was saying that Zolo, but it is Dylan. Sorry, Dylan.
No worries.
And I have just to complete comment about this.
Thank you to Dylan. That thank you.
Okay, so great. Okay, great. And I have one comment, like you said, you talk about vascularization. It is nice, but it's good to know the system port hypothalamo-hypophyseal. It is very complex system. You have to know about pituitary gland. And I have comment, like you said, like Dr. Kabulo said, obviously it's not just transcranial approach, endoscopic nasal, but sometimes if the tumor extended laterally, sinus cavernous, you have to perform endocranial approach. And nowadays, you have to know that you have pituitary adenoma, functional and non-functional. And depend the type of the tumor, you can, and depend the type of the tumor of the tumor, the size of the tumor. You can go first to medical treatment and see, or going to obviously depend the clinical status of the patient. So you have always in your mind to have these three steps in your mind. What is the clinical status of my patient? What is the size of the tumor? And you have to done many tests to know if your adenoma, your pituitary gland adenoma is functional or non-functional. And depend of all that, we can planify the good management. And nowadays, we perform radiosurgery, sometimes directly, but sometimes we perform that after decompressed, after reduced tumor volume. And we go also after that radiosurgery, hysterotactic radiosurgery, to have good outcome, because we know that recurrence, we can see recurrence in few cases about adenoma, pituitary adenoma. In case that you don't remove all the tumor, because sometimes you can have residual tumor in sinus cavernous, and you know that you don't have to go there. So sometimes you have to complete your management with radiosurgery. So that is my comment about that. And I think you talk about many things about this topic, and I encourage you, and I hope you will very done neurosurgery, and I would like to work with you, with all of you. So thank you very much.
Well, I tell you, Dylan, you're so lucky. You have two neurosurgeons critiquing your talk. I mean, that doesn't happen very often. Getting personal attention. This is fantastic. And thank you for being patient with the tech. We got it done. And one thing, I'm not a neurosurgeon, I'm a regular doctor, but one question I have probably for Dr. Kabulo and Naru is that I know that pituitary surgery is also part of an ENT doctor's area of operation. Do you have other ENT doctors in your area that do that type of surgery, pituitary, through the transsphenoidal approach, or is it strictly the domain of the neurosurgeon?
Pituitary is for neurosurgeons, but ENT surgeons, sometimes they do scalp-based. Like here in my center, sometimes when we are doing the transsphenoidal approach, we involve the ENT. So we go together with them up to the sphenoid sinus, then we remove the tumor. They do also scalp-based. There are ENT surgeons who are also sub-specializing in scalp-based. But the pituitary, it's mainly neurosurgical.
Mainly neurosurgical. What percentage is
Yes, of course, I will add that sometimes. So when the neurosurgeon don't have a lot of experience about this area, they can call of the help of otorhinolaryngologist doctors who can help to make the approach to the cellar, and then the neurosurgeon go ahead to remove the tumor. Sometimes. But like Dr. Kabulo said, unfortunately, sometimes we operate that with our school-based neurosurgeon help. Yes.
okay? Have you neurosurgeons, have you operated much on the pituitary?
Yes, we
Naru and
do.
Dr. Kabulo, have you actually
Yes,
done? You have
sure.
on the most.
Yes. But I didn't remove yet pituitary adenoma, but I done the approach to the cellar. I help sometimes about the endoscopic transsphenoidal approach. I help to done the approach, but about endocrine approach, I done perfectly the approach to the chiasma, the area of chiasma optic. Yes, but I don't remove yet the tumor. But the approach to attend, I done that perfectly.
I imagine medical management is important with pituitary problems. And
Uh,
you probably enlist the aid of an internist or endocrinologist. Do you do that, or you strictly concern yourself with the operation, or do you try to manage the endocrinological aspect of it? Hello? Did I go down?
Hello,
I don't understand your question, John. Can you repeat, please?
Yeah, sure. Okay. Do you guys manage the endocrinology part of the pituitary problem, or you leave that to the internist or to the consultant?
like Dr. Bennett, in my center, what we do usually, if we get a patient like that, we send the patient to endocrinologist
Okay.
for them to assess the patient, correct something. If there is a hormonal imbalances, they can correct and give us a green light to operate. They can say, okay, this one is now fit for surgery. So all patients we are operating for pituitary, we do send them to endocrinologists for their assessment before surgery.
Okay, so they have to
Yes.
they have to be cleared by an endocrinologist
Yes,
to
true.
operate.
Yes, of course. Like Dr. Kabulo said, it is like I was said last time. I depended the type of adenoma pituitary. If it is functional, obviously, immediately after surgery or before surgery. And in my center, we done this approach when it is functional adenoma pituitary. We done multidisciplinary plenary like staff. And we discuss the case about with endocrinologists to have a good management. Then if the endocrinologists have to start first the treatment, that can help reduce tumor before going to surgery. And if we don't have any comprehension about the chiasma optic and we have good clinical status, we can just let medical treatment and see the outcome and follow up. And but obviously after surgery in functional adenoma pituitary, we send our patient directly to complete treatment with endocrinologist. It is the gold standard treatment nowadays.
Okay, this question is by a non-neurosurgeon again, and may seem a little different. Now, when you operate on a pituitary problem, you can go transsphenoidally or you can go through the cranium. Now, do you do the endoscope also through the cranium when you approach it that way, or you don't approach it? You always transsphenoidal endoscope.
Like us, when we are doing transcranially, usually we use the microscope.
Microscope?
We use the microscope, yes. And usually we do the eyebrow incision. Let me show you an image of a patient we did last time. You see from where we are going through, we do the subfrontal approach. Let me try to share the screen.
I will complete before Dr. Kabulos shared her screen. Just know that we don't just have in this area adenoma pituitary gland. We can also have craniopharyngioma.
Yes.
We can also have many type of tumor, not just only adenoma pituitary. We can have like our last case we will publish so soon with my young colleagues, Dr. Jose. We can have abscess of pituitary gland. So not just adenoma pituitary gland we will have in this area. So sometimes we can perform on endoscopic transcranial approach, no. But in endocranial, it is microscopic. And sometimes we use microscopic to perform transcranial transfemoral approach, not just only endoscopic. We can use the same technique with microscopic in transcranial approach, because it is not all neurosurgeons who know to use endoscopic. So the first, I think in curve line of surgery, we have to know how to operate with microscope. With this approach in transcranial sphenoidal approach with microscope, and also go to endoscopy, because with endoscopy sometimes it's so easy, but sometimes it's not easy. So it is important to know both technique. It is good to know this both technique.
Well, you know, pituitary gland is right in the middle of the brain, right? A lot of dissection to get to it is right in the center of the brain. And that's a non-neurosurgical question, I know.
You say, John? What is your question?
No, is the pituitary, it's right in the center of the brain. It's a lot of dissection to get to it, correct?
Yes.
Okay.
Yes.
Okay, very good.
Yeah, like Dr. Nur was saying, there are many things there to use, even the transphenoidal approach, not only for pituitary adenoma. If you just get differentials of cellular region tumors, there are many of them. There are many, even meningioma, tuberculum cellular meningioma, you can get the dermoid cyst. There are many things around there when you're like trying to make your differentials. So not only the pituitary tumor. And it also depends, you have to do your imaging before you see, you decide about the approach from your images you are getting before operation.
Okay.
Then
Go ahead.
Then maybe it would have been better to choose as topic for the presentation cellular approaches, so that maybe we would have covered a broader spectrum of.
Sure.
Yes,
No.
of course. I think that we talked about that with Ulrich and John. After all this lecture, we will go for approach. We will go for technical approach lecture. So now we just done neuroanatomy, but we talk about pathology. But after all this session of this lecture, neuroanatomy, we will go ahead with if Dr. Kabulo have time, we will done a good program about approach, technical surgical approach, and we will talk about that. And we will go back for surgical anatomy. It is not the same like that. But now I see that sometimes we go to surgical anatomy, but when we will talk about surgical procedure, we will talk more about surgical anatomy, and we talk about more technique about surgical procedure. And don't worry about that. We will talk about that so soon.
Thank you so much, Dr. Nuru. That's a great suggestion. That's a good suggestion. What we are going to do, let us finish with anatomy, then we'll go back about approaches. We'll just take, for example, a week for posterior fossa approaches. We talk about all approaches. We can doing 2 approaches per presentation. Dr. Nuru will come like, let me get an example. Posterior fossa approach, Dr. Nuru can come with the teleovelar approach. I will talk about retrosigmoid approach. The next day, we take again more approaches. I can take far lateral approach. He takes extreme lateral approach. We finish that, then we go approach. We talk about approaches to the cellar region, approaches to the pineal gland region, approaches to the tumor which are in the ventricles, and so on. So we can still discuss about approaches later on. Let us finish this series of anatomy, then we'll plan how to do approaches.
Exactly, exactly. We will do that, and we will talk also about pteronal approach. We talk about subfrontal approach. We talk about many approach in neurosurgery. So don't worry, guys. We are with you. We will do great job with you. Don't worry.
Yeah, we appreciate you guys coming. You know, this is fantastic. We got through this presentation. Sorry to say that Zolo's presentation on the cerebral cortex will not take place today. It'll take place next week. And we'll wrap this up now. You guys stick around, we'll chat, and I appreciate you guys coming out. So we'll end this formally. Thank you.